Cricotirotomy is an essential skill for clinicians faced with critical airway emergencies, often performed under stressful conditions. To ensure a more effective implementation, the approach to cricotirotomy has evolved with the introduction of the scalpel finger bougie approach. This walkthrough video will take a step-by-step approach to demonstrate the technique and address some important challenges the practitioner may encounter. Since cricotirotomy is a low-frequency skill, it's important that the skill is regularly practiced, preferably observed by your colleagues to maximise the learning opportunity. Within the difficult airway guideline, cricotirotomy is indicated when the patient can't be intubated and can't be oxygenated, or CRICO for short. In this context, cricotirotomy is undertaken to establish a successful airway in the event of all other airway strategies failing to correct descending oxygen saturations. The emphasis here is can't oxygenate. Maximising oxygenation throughout intubation is central to patient safety. To this end, the Difficult Airway Guide supports the use of cricotirotomy at any time where intubation is not possible and descending saturations cannot be corrected. Importantly, any practitioner willing to engage in RSI must also be willing to undertake cricotirotomy if CRICO develops. Therefore, the team must clearly identify the location of the cricotirotomy equipment and the role it plays within the pre-RSI brief. This is essential to a team-based approach to airway management. In addition, cricotirotomy may be initiated as a primary airway. Here, the patient is deemed unsuitable to be RSI'd and cannot be oxygenated by standard airway adjuncts. It's important to take the time to refamiliarise yourself with the circumstances which would indicate cricotirotomy as a primary airway strategy. Importantly, there are no contraindications to cricotirotomy when oxygenation and ventilation cannot occur with other techniques in the unconscious adult greater than 12 years old. If at any time the practitioner finds themselves in a can't intubate, can't oxygenate CRICO situation, cricotirotomy is not only indicated, it will be life-saving and provide a successful airway. The precautions will be touched on throughout this instructional video. The health and safety of all present must remain a high priority. Significant hemorrhage should be anticipated at the insertion site, and atomising or spraying blood is possible, particularly if the patient is attempting to breathe. A face mask and eyewear are essential in addition to the standard PPE. Practicing this skill with PPE donned is recommended to ensure familiarity with the challenges and for developing appropriate safety habits. The following equipment should be readily available and identified before proceeding. This can be pre-packaged to ensure easy access and completeness. You'll note that all this equipment is already present in the current airway kit and can be rapidly assembled in the event of a prepared kit not being available. To aid recall, the scalpel finger bougie procedure can be broken down into 4 well-defined steps. Step 1. Identify the cricothyroid membrane landmarks, perform the incision, and cut to air. Step 2. Dilate the membrane with your little finger and guide the bougie insertion down the trachea. Step 3. Railroad the ETT and inflate the cuff. Step 4. Commence ventilation, confirm placement by capnography waveform, and secure the ETT. Let's go through the procedure in more detail. Although cricotirotomy is a critical task requiring rapid intervention, it's important the team is involved and an airway assistant is allocated by the lead clinician. In RSI, roles should be identified during the brief. If a CRICO situation evolves, anyone within the team can verbalise this, clearly stating that CRICO has developed. If CRICO is called, the team must immediately address this statement and identify if this is indeed the case. Once a CRICO situation has been identified, the lead clinician will undertake the procedure and provide a rapid brief, if not already done. Ideally, this procedure should be performed using the dominant hand so position yourself accordingly. Additional team members provide support, including holding the head in the hyperextended position, verbalizing vital signs, including heart rate, oxygenation, and capnography, and, where primary cricothyroidotomy is being undertaken, continued attempts at oxygenation may proceed. However, in the setting of the difficult airway guideline where CICO has developed, further attempts at BVM can proceed, but should not delay nor complicate the establishment of cricothyroidotomy. Lay the pre-identified equipment out on a clean, accessible, and flat surface. The assistant applies medical lubricant to the distal ends of both the bougie and the ETT. Try to avoid handling the lubricant since it might reduce your dexterity. Ensure the bougie is reasonably straight and without hockey sticks or kinks. Exposing the front of neck anatomy is an important step towards successful landmark identification. If possible, elevate the shoulders to encourage neck hyperextension. Also, tensioning the submandibular tissue will also assist exposure of the anatomy. Consider using a team member to maintain hyperextension, or change the position of the patient, such as placing the head over the edge of the bed. Firmly grasp the identified larynx and stabilize it with the non-dominant hand, ensuring that the skin is held taut. Now, confirm the landmarks. Note that the larynx will move if the patient is spontaneously breathing. Using the scalpel, make a 4 to 5 centimeter midline vertical incision through the skin and subcutaneous tissue to reveal the underlying cricothyroid membrane. That is, cut to expose the anatomy. A longer incision may be required if the underlying anatomy is not easily identified, such as the bariatric patient. It's important to ensure sharp safety at this point and not to dispose of the scalpel prematurely. Again, using your non-dominant hand, spread the skin apart to assist identification of the airway structures, feeling for the membrane with the scalpel hand. Having identified the cricothyroid membrane, either visually or by touch in the event of excessive blood, cut to air with a horizontal incision through the membrane. Be careful of atomized blood spray when cutting into the cricothyroid membrane, particularly in the spontaneously breathing patient. With the non-dominant hand, insert your gloved little finger into the incised membrane to dilate the opening. Rotating your finger might help. Ideally, the posterior cartilage wall should be palpated, but this is dependent on the patient's anatomy. Maintain insertion of the little finger. Never leave the newly formed hole unattended, so keep the finger in place until the bougie replaces it. Place the bougie inferior to the inserted finger while guiding it into the trachea towards the chest until resistance is felt. Don't force the bougie, as it will often get held up at the carina. Remove the finger once the bougie has been completely inserted, ensuring the bougie remains in place. ETT insertion follows the familiar practice of railroading a tube over the bougie. With assistance, the lead clinician pushes the lubricated size 6 ETT over the bougie through the dilated membrane. Rotation of the ETT during insertion may assist passage if resistance is felt. While the size 6 ETT is indicated in adults, a smaller ETT may be necessary for smaller adults or children between 12 and 16 years old. Once the ETT passes through the dilated incision, stop insertion when the cuff is no longer visible outside the larynx. Right main bronchus intubation is a common consequence of this procedure, so ensure correct positioning. The lead clinician then grips the ETT at the insertion point to ensure the correct position is maintained, and the assistant removes the bougie. Avoid flicking body fluid from the bougie by ensuring the assistant grasps the base of the bougie as it exits the ETT. Inflate the cuff with 10 ml syringe or manometer. While the lead clinician maintains a grip on the ETT, the assistant immediately attaches the BVM and capnography, initially performing gentle inflations until ETT placement is confirmed. Resistance to ventilation may suggest extra tracheal placement has occurred. Verify tracheal placement by capnography waveform. While waiting for waveform to establish itself, identify subjective signs of tracheal placement, including chest rise and fall, tube misting, and improving saturations. The presence or absence of an adequate end-tidal CO2 waveform must be noted by all paramedics present. If there is any doubt about tracheal placement, the ETT must be immediately removed. Correcting hypoxia now becomes the priority. The lead clinician will identify and verbalise a manual ventilation strategy and target physiological parameters to the team. It may be prudent to focus on reoxygenation first prior to securing. Have the team cycle through all other vital signs to provide an overall awareness of the patient's status post-procedure, and auscultate the chest bilaterally to assess ETT depth. Continue the ventilation strategy while gripping the ETT at the base during securing. It's not uncommon for the ETT to be accidentally pushed further down the trachea during this stage. Consider marking the ETT or placing tape at the securing point to identify the insertion length for continuing insertion depth reference. Let's summarise by reviewing the 4 steps of the procedure. Step 1. Identify the cricothyroid membrane landmarks, perform the incision and cut to air. Step 2. Dilate the membrane with your little finger and guide the bougie insertion down the trachea. Step 3. Railroad the ETT and inflate the cuff. Step 4. Commence ventilation, confirm placement by capnography waveform, and secure the ETT. We hope you found this video useful. If you have any questions, approach your educator in the first instance or contact us at clinicalguidelines@ambulance.vic.gov.au.